4 minutes past 10. I'm going to get started. Thank you all for joining today. It's really nice to see many of your names, if not faces. Today we're going to talk about, really this is a chance, I think, to look back over the year and reflect on what I think has been a somewhat seismic shift in using mobility data from mobile phones in applied public health. Before we start, I'd like to apologize for the sounds of my children if they in the background. But so this year has been obviously a pretty wild ride, but I think for those of us who are in the field, infectious disease epidemiologists, from science all the way through to applied public health, which is the panel that we have here, we really have seen a big change in how data from mobile phones is now being routinely used in public health in the context of the COVID-19 response. Prior to 2020, I would say that it's fair to say that these kinds of approaches where you use mobile phone data to monitor mobility and other things was kind of a niche field within ID-Epi and largely an academic exercise where it was very much proof of principle, and there'd been a lot of discussions about how you would integrate these data sets into a routine surveillance effort, but it hadn't really happened on a wide scale. And then when COVID-19 happened, we've really seen just an explosion of these data sets in terms of their availability, their scope, the interest in them from policymakers, and a shift in the thinking from academic proof of principle to really applied. How can they be used? Where are they going to be used? And one of the things that has happened as a result of that shift is that those of us who have been in the field that has been, I think, quite conservative with respect to privacy and how we view these data sets in terms of what's appropriate use, where the uncertainties are, how applicable they are. A lot of that has been sort of thrown out of the window, and we've seen a lot of use of these data sets by academics that haven't traditionally used them, so they're not necessarily familiar with some of the work on privacy, as well as by governments and businesses where they've, in an effort to make data useful and available, we've seen companies really put out data which I think is questionable in terms of privacy. So this is kind of really changed the landscape for the use of this kind of data in epidemiology, both from a science perspective and in public health. So today's panel, what we wanted to do to reflect really the trajectory of the COVID-19 mobility data network, which we started way back in March. We wanted to reflect on how far we've come, and we thought that a good way to do that would be to invite people from across that pipeline, from the science and academia side, and then talk to more applied researchers and practitioners who are using these data sets on a daily basis or near daily basis, and really try to think through how far we've come, where these kinds of data sets are useful, which data sets are useful for which kinds of questions in epidemiology and public health, and then what we think may happen in the future. So at the end, I hope we can have a discussion about what we think the future of these kinds of approaches will be in public health. So is this going to now be a routine kind of approach? Is this now a data set that will be routinely available for policymakers? And if so, where are we with privacy? And is there some kind of lag that we need to catch up on to make sure that we are not drifting between public health surveillance and state surveillance and trying to walk that line? So I'm delighted to welcome our panelists here today. We are going to start with Gregory Wellenius, who and Gregory will hopefully introduce himself and say a bit about what he does. Each panelist will talk for about 10 minutes. And I think maybe we can have a few minutes of Q&A after each presentation. And then afterwards, I hope that there will be time for a discussion, including Q&A. And so if you want to put your question into the chat, I think Sachin and others are going to help me kind of filter through those, and so that we can integrate them into the discussion at the end. So I will, without further ado, I will pass it over to Greg. And welcome everyone, and I look forward to a really interesting discussion.
Okay, great. Thank you, Caroline, for the invitation to be here. So, right, by way of introduction, my primary appointment is as a professor of environmental health at the Boston University School of Public Health. And this year, starting in January, so pre-pandemic, seems like a lifetime ago, I had the opportunity to spend a year working as a visiting scientist at Google Research. We, of course, weren't thinking about anything pandemic related when we lined that up. I can talk more in the Q&A about what we intended to do and what we are doing there, but found ourselves in this incredible moment and were able to, I had the opportunity to participate in the launch of the Google's community mobility reports. So what I want to do today is talk a little bit about the data. I'm not an engineer, I'm primarily an epidemiologist, so I won't go into sort of the engineering aspects of that. That's not my specialty, but happy to answer questions about how to use the data, how to, the insights that can come from the data, and I'll show you an example of how we used it in a research project that you can read the paper online. So with that, let me give you my disclosures that I am a visiting scientist at Google for this calendar year, and the opinions expressed here are my own and do not reflect the opinions of Google. Okay, so of course, the pandemic, we became aware of that in sort of February and March, and coincident that we started working internally at Google. I was part of a team that started developing the community mobility reports, which were launched publicly in March. And essentially, this is a way of saying, based on people's location history data from their interaction with Google and Google Maps, how the change in behavior over time and change in mobility over time. And these were initially launched as PDF files for each region, and then subsequently the raw data was released as PDFs. Sorry, as CSV files. The metrics show change in frequency, the relative change in frequency to visits of categories of places. So this included retail and recreation, grocery stores and pharmacies, parks, transportation, transportation stations, etc., as well as visits to places of work. And importantly, I think when you think of in an epidemiologic context, I think the most interesting variable was the change in the amount of time people were spending at places of residence. As I said before, these metrics are based on location history data. This location history is capitalized there because that's a Google feature that you can opt into. It's off by default. You can opt in, and if you want to, if you check on the website, there's where you can view your own activity and opt in if you want to, if you're not already, or opt out if you want. So these data are highly aggregated. They were released on a daily time scale at the county level in the US and county equivalents in other parts of the world. And the metrics that are released undergo a differential privacy process to maximize anonymity. And again, it's expressed as a % change from the baseline value from January and February. These are continue to be freely available. They're updated, I think, approximately every 3 days. So the anonymization and differential privacy process is described in quite a bit of detail in a publicly available white paper. So you can see the link there, and I'm happy to make these slides available to you, Caroline, if you want to post them or distribute them afterwards. But that's easy to find on archive. And these have been, the adoption of the community mobility reports and the underlying data was really impressive from my point of view. You saw them in the media all the time. They were, lots of, especially as soon as we made the CSV files available, there was lots of visualizations based on this. This is one of my favorites. This is our World in Data, which is associated with Oxford University. So this is not a Google visualization of it. So this happens to be for the United Kingdom, and they have, these are animations on their website, but just shown statically here. So you can see that starting in March, there was a decrease in, a very pronounced decrease in visits to places of different categories: transit stations, retail, recreation, workplaces, grocery and pharmacy, and parks. And then presumably as the weather got nicer and people realized that being outside was relatively safer than being near people inside, there was a substantial increase in the number of visits to parks, which has gone down again as, both indoor operations have resumed and as the weather has become less favorable to that. And there's been this sort of residential signal here. This is the relative change in the number of hours that people are spending at their places of residence. And you can see that there was an initial uptick, which has, not completely recovered to baseline levels, at least in the UK. And so you can do this for any country or any county equivalent in those countries, and you can compare across countries. So this is, again, available from our World in Data on a animated basis, or you can download the data. It's a very nice platform for doing that. And, this was on, April 16th. You can see sort of compare the relative decreases in mobility across country. You can see that Europe had, relatively pronounced decreases, whereas North America had relatively less decreases in mobility. So we decided to take these data and test out a couple hypotheses. We really wanted to see how useful was this data in order to, there were lots of social distancing policies being put in place. We started in the US, and in the US at the state level, there were, you remember, nearly every state declared a state of emergency, and then there were an array of different policies to promote social distancing, and they varied by state quite a bit. And so we thought that that was an opportunity to investigate which of these social distancing policies actually reduce mobility the most. And then we wanted to connect that change in mobility to a change in case growth rate in the subsequent couple of weeks. So this is just showing that in the first wave of the pandemic here, so going from March through mid-April, you see the different colored dots there, and with each row representing a different state. So different states declared states of emergency at different point in time, but all within a couple of weeks of each other. And then there was this sort of smattering with relatively close timing, but some heterogeneity in the timing and lots of heterogeneity in the types of orders. So ranging from school closures and large gathering bans to bar and restaurant limits, closures of non-essential businesses, and towards the later part of the first wave, several states enacted shelter in place, required stay-at-home orders. So then you can look at, do a pre-post comparison of how did these different social distancing orders impact mobility. And for this work, what we did is we turned the variable of the time spent, the relative change in time spent at places of residence, to flipped it around to the relative change in the number of hours people were spending away from places of residence, because we thought that that was the variable most connected to the risk of infection. When you're not at your place of residence, that's when you're exposed to more likely to be exposed to other people and contract the infection. So we turned that variable around. And so you can see here is that the emergency declaration in each state was associated with somewhere around a 10% decrease in time spent away from places of residence, decreased time of visits to workplaces, retail, recreation, transit, and parks, and an increase to grocery and pharmacies. And you remember we were all rushing out buying everything off the shelves, and there was sort of these mad rush, and that's reflected in the mobility data. And then a week or so later, when the social distancing orders started coming out, then that caused a much more pronounced decrease in the relative amount of time people were spending away from home, and visits to workplaces, retail, recreation, transit, et cetera, including groceries. So then people were really staying put, not going out as much, And you saw that in the mobility to visits to different categories, as well as just the number of hours away. And then on the far right there, you see that the shelter-in-place orders had the most pronounced effect on encouraging people to stay put and not go out, not go visit places of all categories. And what we did there is just compare the temporal sequence of those states that had a shelter-in-place order in the dark gray versus those states that at the same time did not have a shelter-in-place order. So you see that mobility decreased everywhere, but it decreased more for those states, or in those states that had shelter-in-place orders. So then we wanted to explore, is this, what I showed you on the previous graphs was the average effect across the country, and we wanted to see how much variability is there within state and between states. So remember, the data in the US are available at the county level, so we were able to look at the within state variability at the county level, or as well as the between state variability. And we see there's quite a bit of variability with a couple interesting patterns emerging. One is that the more social distancing orders that were put in place, so these are things like, again, the large gathering bans or the school closures, restaurant and bar limits. So the more orders that were in place right at the beginning, the more that the bigger impact on mobility. That's not surprising, but it's nice to document it. And we were actually surprised by how much within state variability there was. You can see, in a state like New York, that there was, a wide range from sort of very steep reductions in mobility to less, quite minimal or quite modest reductions in mobility. So important variation when we look at this. The other thing that was that we tried to get at, and we can only do this so much given the concurrence of the timing of the orders within and between states, but we were trying to see which social distancing order is the most effective in limiting mobility. And so the pattern that emerged there is that the more orders, more restrictions on people's movements and activities that you put in, then that caused the biggest change in time spent away from places of residence. And if you had to impose just one single order, restrictions on bar and restaurants, or bar and restaurant limits, was the single order that had the biggest impact on mobility. And then finally, we wanted to connect those changes in mobility, particularly the change in the hours people were spending away from their places of residence, to subsequent COVID-19 case growth in the 2 weeks later, 3 weeks later, 4 weeks later. And you can see that just a 5% reduction in mobility and in this metric of time spent away from places of residence is associated with a 10% or 20% decrease in the number of in the COVID-19 case growth rate in 2 or 3 weeks later. The bigger the increase, of course, the bigger the decrease in mobility, the bigger the decrease in subsequent case counts. So these sort of quantitative estimates, we hope are useful to the public health community in trying to decide which social distancing orders are effective. They're not all equally effective. And then how that translates into actually a health benefit. And if you want to see more details about that, that's publicly available on the archive. And I'm happy to talk more about that or answer questions.
Thanks so much. That was very interesting. So I did have a few questions, but I wonder whether we should wait until the end of the talks, because I suspect some of them are quite general. So I have questions about the spatial resolution of the data and the utility of, for example, a national level, metric, and how useful that really is for specific decisions that have to be made. But I suspect that's the spatial resolution question is going to come up again and again. And then the other one that I think is a general problem that a lot of us have run into is trying to fit models or trying to make sense of case data where we know testing is just wildly insufficient. So you're fitting a model to what may or may not be true, the true epidemic growth rate. And even if you use death data and try and back calculate, you've got uncertainty, a huge amount of uncertainty in what your your growth rate estimate, coupled with uncertainty in terms of the spatial resolution with your mobility changes. Maybe, but I suspect this is going to be a common theme. So maybe we can hold
really,
off.
All really important points, all really important challenges. I look forward to getting into it with the entire panel.
Yeah. Okay. And yeah, somebody has put into the chat as well. You know, trying to stratify by socioeconomic status as well is something that will come up again and again, because I think, you know, as a defining feature of this epidemic, it's been very local and it's been very much driven by socioeconomic status and race, ethnicity in this country in particular. Thank you. We'll come back.
Caroline, sorry.
Yes.
Hi, sorry, this is Lauren. If it's okay, I do have one quick question that's specific to this. Is that okay?
Yeah, sure, yeah.
Hi, Greg, this is Lauren Gardner. I just was actually curious on the temporal resolution. So for some of the analysis that you were showing, where you were showing all the percent changes, and those were specific to different policies and they were by state. I was just wondering, because the states implemented all the different policies at different times. So was that all accounted for? So it was relative, because I know with the metric, it's relative to some baseline, but were those the difference between the baseline and then some period of time after the policy was implemented in each state? And how did you deal with that?
Yep. Yeah. So that's great. So each state did implement their policies at slightly different times or in slightly different orders. And so what we're doing is comparing the mobility in the week after, in the 7 days after the implementation of the policy, with the same metric in the 7 days before the policy was implemented. But we left a two-day blanking window there because there's often a lot of messaging around, like, we're going to declare a state of emergency or we're going to impose this restriction. And so, you know, the actual change in mobility, you know, we didn't want that sort of the messaging period to be included in the pre-period. So we took sort of days -9 to -2 before the policy as the baseline, and then days, you know, 1 to 7 after the policy implementation in a state-specific way. So one of the other comments in the chat there is about, but several counties had implemented their own restrictions before the state level policies. It's absolutely true. One of the limitations of this work is that there isn't a national database at the county level in the US of when different policies were implemented. We do show a couple examples in that paper from Seattle, which was an early known hotspot that, you know, took proactive steps to try to limit that, and same thing with New York City. And so you can see again in great detail the change in mobility coincident with announcements and then the actual implementation of social distancing policies.
Yeah, great, thanks.
Thank you. So in the interest of making sure we get to everyone, Greg, would you mind going back through the chat, and just if there's any questions that are specific for you, maybe you can answer them. That'd be really helpful.
I'll do that. Thank you.
Thanks. Okay, so now we are going to move to Jure, who I'm going to try and pin your video. Where are you? There you are. There. So now I have to do something else. There. So Jure, I will just, I will let you go ahead.
Okay, thank you very much. Thank you, Caroline, for the invitation to this interesting panel. So I'm a computer science professor from Stanford, and I will discuss our work that we have recently published in Nature about how can we use fine-grained mobility data to model the spread of the coronavirus. So the way we started this was basically just in March, when the outbreak happened. We were like, is there anything we can do to help? And it is interesting that basically 8 months after the outbreak, there is still a lot of debate about, you know, how do we reopen the economy? What places do we reopen? How do we reopen? And this is really the lens through which our work approaches this area. And what I want to do is I want to tell you about our findings and our reasoning when we were doing this paper. And essentially, the way we started, what I research in is large-scale social and information networks and knowledge graphs, and then I do machine learning and data mining on top of them. So viruses are another example of phenomena that spreads over networks. And in the past, I worked a lot with Facebooks and Twitters to understand how information propagates and how things become viral. And that's kind of where we come into this. So basically, the idea is, right, like viruses spread through human contacts. And what this means is that there is the underlying human contact network that modulates how things spread, right? So this means that there is this underlying set of connections, of contacts between people that would allow us potentially to accurately model the spread of the virus. Right, and if you have that network, then you can have a relatively simple, rudimentary epidemiological model where basically you can say that when two people come in contact, an infectious one infects a susceptible one with some small unknown probability, let's say beta, right? And then as you start with a couple of infectious people, these infections can spread through this dynamic, unknown, latent contact network. So what is one of the main problems in modeling these types of processes is that we don't know what is the structure of the underlying network, right? Is the contact network like here on the left, or is it perhaps the one on the right? And this would have amazing consequences for how the virus would spread, given what the network is. So and because the network is often unknown, what do kind of generally the models do? They assume a fully connected graph, right? They would assume some kind of complete mixing. And that's a kind of, if we are honest, quite unrealistic assumption. So when we came to this work back in March, our premise was that human mobility patterns are crucial for us to be able to accurately model virus. So the question was, can we accurately estimate the dynamic contact network of, let's say, 100 million people? Can we do that with today's technology? Is this possible? And kind of our premise when we went into this work was that if we can estimate this human contact network, then we can accurately model the virus. And not even that, we can then be able to answer all kinds of what if questions in terms of social distancing, in terms of reopening the economy, and so on. So this is how kind of we came to this work. And the idea was, right, that if I can use cell phone data and I can see how people move around, then I can determine who is in proximity of whom, and it will allow me to model the spread of the coronavirus. And in particular, in this work, we modeled 10 largest US metropolitan areas that have combined population of 100 million people. And we are able to estimate the contact network for every hour of every day over the course of our study, which is from the beginning of March to the beginning of May. So we are using data coming from a company called SafeGraph. This is anonymized, aggregated data coming from cell phone applications. The data is actually freely accessible. It gives you the number of visitors from each neighborhood, from each census block group. It tells us visit duration, so what is the median time that people spend at a given location. It gives us also the square footage area of a given location, and also they estimate the fraction of people that stay at home. And if you'd like to play with this data, you can download it at this URL below. So what we did is we built a network inference module that basically allows us, given the SafeGraph data, given the US Census data, as well as given the case count reports from New York Times, we basically are able to estimate for every hour of the day the dynamic network that tells us how people from different census block groups, so basically from different neighborhoods, these are units of about 2,000 to about 600 people, visit different points of interest. These are individual points of interest like restaurants, gyms, coffee shops, grocery stores, and so on. And we have about 500,000 of these points of interest, about 60,000 different neighborhoods. And we infer this network where an edge tells me how many people from a given neighborhood visited a given restaurant for every hour of the day through the duration of our study. So for every hour, we infer this type of dynamic network that is large. And then what we do is on top of this, we overlay a relatively rudimentary or simple SEIR model that has just 3 fixed parameters. So basically 3 free parameters that are fixed over time. And these are the initial number of infected people, and then the beta, the infection probability at the neighborhood level, and 1 at the point of interest level. So really 3 free scalar parameters fixed over time. And then to show you how these networks look like, here is, for example, the mobility network for 1 p.m. on March 2nd for Washington, D.C. And here is the same type of network for April 6th. And you can just kind of visually see how fewer connections are there and how the mobility dropped. This is now between the census block groups and points of interest. Vertical lines are basically going to a coffee shop in your neighborhood. Diagonal lines means you have to kind of travel to a neighboring somewhere far. That's basically the idea. And then we fit our model to these different data. We simply fit it to the raw case counts as published by the New York Times. Here I show you the raw case count data in this red gray axis. We also show the reported cases smoothed out in orange line and the prediction of our model in the blue line. And what is interesting here is that our model is able to, in this case, I show you 4 cities. In total, we did 10. These cities have very different case trajectories, but our model is able to capture these different dynamics, regardless that it has very simple fixed set of parameters that don't change over time. So that's kind of how we fit the model. And then, what can we do with it? For example, we can be asking, as previous talk very nicely showed how mobility dropped. We can now be asking what would happen if mobility would not drop, right? Like imagine we take this last week of February and we just repeat the mobility over time. What would have happened? And what is interesting is that you can basically predict what would happen if we wouldn't socially distance or stay at home. And the model predicts that with no reduction in mobility, 32% of the entire population would be infected within a month, right? And this is over time. Yellow is what would happen with no reduction. Black is what happened with the reduction. And then, if we would reduce the mobility less than what we did, what would be the case count trajectories as predicted by the model? You can also ask, was it important when the exact drop in mobility happens? It turns out it's kind of less important if we are talking at the level of days or weeks. You can see that basically if we were to drop mobility 7 days earlier or later, it wouldn't have such big effect on the number of cases. We can also ask various kinds of what-if questions in a sense. For example, what would happen if we fully reopen a given type of point of interest? We assume people go back to these points of interest as they were attending them at the end of February. How many new infections can we expect? And essentially, if you would reopen full service restaurants, this is on average over all these 10 cities, you would have about 6% population infected in a month, again, under the conditions of the first wave, which means much less mask wearing and things like that. What we also find out that there is a very high disparity or unevenness in terms of number of infections that are predicted to account at different points of interest. It's about 10% of points of interest that account for over 80% of all infections. So basically, these are few points of interest where people are densely packed and stay there a long period of time. And in our model, we both take into consideration the square foot area as well as the duration of the visit of people in these places. We can also simulate various kinds of economy reopening scenarios. It turns out that you get very interesting kind of nonlinear effects. For example, we test different types of scenarios where you say, what would happen if we use this maximum occupancy capping type reopening strategy? If you were, for example, to reopen all the points of interest at 20% maximum occupancy, this would cut down the number of infections by more than 80%, but you would be only losing about 40% of the total visits or total business in some sense, because most of the time or sometimes during the day you are operating below 20% maximum occupancy. So it allows you to basically run these types of what-if questions. And because there was a question about social disparities, one question we asked our model is, basically we just fit it over the raw case counts, as I said, at as reported by the New York Times at the metropolitan area, so not even at the individual counties. And what is interesting, we asked, is our model able to capture this disparity between high income and low income neighborhoods, where we observe much higher case counts in low income neighborhoods? And we actually find out that our model kind of naturally captures this without us ever putting it into the model. And it predicts that this kind of social disparities in infections based on mobility patterns alone. And then we ask, can we explain why is there such a big difference in relative risk between high income and low income neighborhoods? First thing we find is that low income neighborhoods reduced their mobility much less. They reduced their mobility 30% less than high income neighborhoods did. Here I show you a few examples of mobility over time for high income versus low income neighborhoods. So that's the first part of equation. The second part of equation is not even there is difference in mobility, but actually it turns out that points of interest visited by people from low income neighborhoods have higher transmission rates. And for example, visit to a grocery store for someone from a low income neighborhood is about 2x more risky. The reason for that is that they go to places that have about 60% higher density of visitors per square foot, and they stay there 17% longer. So basically, these types of models allow us to come up with these types of hypotheses or potential explanations for some of the disparities we see in our data. So this is really our work. What I wanted kind of to show here, or what I think are some take-home messages, is that these fine-grained mobility networks are super useful and essential for modeling. These things are easy to get, super scalable, and it allows you to do very fine-grained predictions or analysis and identify micro trends down at the level of individual neighborhoods and individual locations. And what are we working on now? We are working on building tools that would allow us to say, if I come up with this type of reopening strategy, how would the population respond in terms of mobility, and what would happen to the case counts over time? And if you are interested to kind of play with the public version of this tool or read our paper, we have the website covid-mobilitystanford.edu. There's a paper, and these are the 3 brave students who made all this possible. Thank you so much.
Thank you, Jure, that's great. So maybe we'll take a few questions. I mean, I think that there's still this problem. So if we compare the Google data set and the SafeGraph data set, the sample size and representativeness is very different. So SafeGraph is much less representative than Google. And there are I think some quite big problems with the SafeGraph data. And so it'll be interesting. We can talk later about like pros and cons of different data sets, especially in the context of fitting models. So if you're fitting models to case data, it's quite hard to know, the case data themselves are also uncertain. So I think one of the challenges for all of us is how we manage uncertainty, how we even quantify uncertainty in the mobility data, because companies like SafeGraph often don't give you any uncertainty measurements when they provide it to you. So I think there are a lot of challenges. I think this is great. And we will have, let's see, there's a few questions here. Jan would like to know why there are no schools in the points of interest data set. Do you know, Jure?
Yeah, actually, there are schools in points of interest data set, and we actually use them in our model. We decided not to make any claims about schools because we don't think the data is representative. There are all kinds of issues. So we use them in the model. They are actually in the data. We decided not to include them in our analysis.
I see. Yeah, because obviously that's on people's minds a lot, isn't it? The role of schools and what that will mean.
Definitely.
Okay, so in the interest of time, and we will come back, Jure, and we'll ask more questions later, but I want to make sure that everybody has a chance to speak. So we're going to move to Jaimie Shaff from New York City. And Jaimie, you're there, I see you. So she is going to talk about implementation of these methods and how decision makers actually use them and how that's changed over the course of the epidemic. So I will hand it over to you, Jaimie. I believe you're not sharing your screen. You're just going to talk to us for a while, yes?
I'm going to share my screen if I can.
Oh, wonderful. Okay.
All right, can you see it? Hopefully.
Yes.
Okay, perfect. All right, hi everyone. My name is Jaimie Shaff. I am the Chief Data Scientist for the COVID-19 response here in New York City for the Department of Health. So today I'll be presenting some work that's been done by quite a number of people. So I've listed quite a few of them here, but this is a really big team that's been doing some great work over the time. So just to introduce you to New York City, we have about 300,000 known cases and over 60,000 hospitalizations. We are at about 25,000 confirmed and probable deaths. As you know, New York City was hit quite hard by COVID-19, and we are currently seeing a concerning trend of an increase. So we are working quite quickly to try and respond to this, implementing a variety of measures. So in terms of phases for the COVID-19 response, this is a visual by vital strategies that we like to use. It gives a pretty good overview of what we're thinking about in from a response perspective. So we've gone from containment, mitigation throughout the first wave, and now we're looking at a potential second wave now. So mobility data, this is from Apple. We've used quite a few different measures, and I'll go through why we use this here. I'm going to give an overview of some of the things that we use. So this is Apple looking citywide. For those of you who don't know, New York City is a pretty large city of about 8.4 million people, and it's across 4 counties. We have a very diverse population, and it is quite mobile, using primarily public transportation. So this is looking at driving, walking, and transit. And as you can see, with New York City, when we went on pause, which was our version of stay at home, we saw a very sharp decrease in mobility, as other presenters have discussed as well. As we started to reopen over here, we reopened in different phases, 1 through 4. And we did see regained mobility over that time, and it's remained somewhat consistent throughout since phase 4, with a slight decrease in recent weeks. One of the things that we noticed early on, I think this analysis was done in the spring, was that it looked as though devices, and there are many caveats with all of the mobility data, of course, but devices from some neighborhoods left the city, and a large proportion of those. So that, of course, impacts the amount of people that could be at risk for transmission of COVID. It impacts our population estimates, and it also impacts mobility. So this was a really interesting analysis that helped explain a lot of the information that we see. The darkest area here is Manhattan, and we did see a large proportion of devices that were registered as with a home base of neighborhoods in Manhattan, leave Manhattan to other counties or states. We also looked at commuting. So many people, of course, commute to Manhattan. This uses Facebook data. Thank you to Nishant. And this helped us understand what type of mobility we might see gains in as we started to reopen. Of course, Manhattan had the most commuters, and so we did end up seeing the fewest people returning. So this is something from our colleagues at Google. This is one of our first analyses that utilized their CSV files, which we were very, very grateful for. So this showed the change in mobility by borough or by county. What we did see across mobility was an indication that mobility decreases were not as great in the borough of the Bronx. And for those of you who are not familiar with New York City, the Bronx is in the north of the city, and it has a very high proportion of people who are living in congregate settings, in overcrowded housing, people of color, and people who are low income. When we looked a little bit further at the neighborhood levels, this is by our modified zip code tabulation area, or ModZipDA, we did see that some neighborhoods indicated that people were not able to stay at home as much as others. So from a health equity perspective, this is really important. We know that there's a high proportion of essential workers who continue to go to work throughout POIS and throughout the first wave of the pandemic. And this requires a different type of intervention. We will need to provide support to these folks, make sure that they have adequate PPE, that they're able to move around safely. And in the event of a transit change or a curfew, this means that these folks may be more impacted than others. This is Google data from more recent weeks. So we've been looking to see if there had been gains in workplace residential locations or losses in residential locations. We did see some changes from when there was a pause, but we also saw that many people are still not returning to the workplace, especially in Manhattan, and people are staying at home. And that end bit, I believe, is Thanksgiving. So we do see some dips on holidays. Something that we're starting to see an indication that there could be more people staying at home in more recent weeks, which we are really hoping is the case, as we have started to see an increase in case numbers in the city, but that could be related to Thanksgiving. This is looking at grocery stores and pharmacies and transit locations. Again, we're looking at this. You see in the Bronx, there's the smallest amount of change. Manhattan has the greatest, and that's pretty much been consistent throughout. Manhattan never really went back to any baseline, whereas other boroughs did. And this is parks, retail, and recreation. And of course, as the weather has changed here in New York City, things have started to go down in parks. So in terms of a response, this is something called the COVID-19 zones. This is a New York State regulation, and in these zones, there are different procedures that are in place. So the orange zones, it's accompanied with school closures, business closures, etc. Whereas yellow zones, it's a few other interventions, but not quite as large. And these zones are updated every couple of weeks. So something that we do expect to see with zones and with zone changes is a decrease in mobility, and that's something that we're looking to now. So in terms of how we use mobility data in our response, we do see this as complementary. I think many of the other presenters have discussed the limitations of the data. And from our perspective, we find it quite helpful to have an idea about trends, but it is to be used as a complement to other quantitative data and qualitative data, which typically comes straight from communities. We have been using data to support and inform our modeling projections. We work with two academic teams at the moment at NYU and Columbia. Columbia uses SafeGraph data for their models. And we've also been looking at out of jurisdiction mobility, which has been really interesting over the months. We did see in the summer, especially around the 4th of July, that there was an increase in out of jurisdiction travel, and then folks coming back into the city from other places. So this has been an interesting look. I think the New York Times does something similar to see if people are coming from areas of higher transmission. We're also looking at neighborhood level mobility changes. So with data that are at the census block group level or at different points of interest, we're able to inform our neighborhood level interventions. So for example, if we're planning to deploy a mobile testing site, we may look at mobility in the area, see where areas may have higher foot traffic, and then talk to communities about to confirm that that is the case. Typically, this has been really successful, and it's helped to make sure that we are putting a mobile unit in the right place. This also, importantly, from a health equity perspective, as we start to see that communities may be returning home or in the event of potential mitigation measures, we really do need to support the people who are not able to stay at home, who still need to go to work, and who are relying on public transportation in case there are any shifts in that. And then, of course, I just need to plug all of our public health guidance. Please don't gather, please don't travel during the holiday season. The transmission of COVID right now is really, really high, and we could have a pretty devastating winter. So we have a lot of options for you here. And then our core 4 messaging, which is stay at home if you're sick, keep physical distance, which is 6 feet as a recommendation, wear a face covering when you're around others and cannot socially distance, and keep your hands clean. And then please go ahead and get tested if you have resources available to do so. And I can go ahead and take any questions.
Thanks so much, Jaimie. Would you mind saying something about how you've seen this data being received on the policymaker side over the year? Have you seen a change? Like, what do you think is the receptivity for using this for decision making? And do you think that moving forward, this will become like a routine kind of approach?
Yeah, that's a great question. I think that all of us, when the mobility data was first released publicly by Apple and by Google and by others, one of the really surprising things was how much mobility actually dropped. I don't think any of us anticipated folks would be as compliant with our mitigation measures as they were in other countries. And that was a really great thing for us because we were able to reassess what modeling assumptions we were going to take. So one of the teams at Columbia uses different percents of decreased contact. So we were able to look at something with much greater decreases than we had initially been using, and that it was really, really helpful. So I think that in general, policymakers have been using mobility data more than before. They ask for it more. We also receive data from the MTA, so we can look at individual transit stations and look at turnstile turns. And I think that, more generally, it's definitely being very well received. And I do think that it's important to make sure that we have caveats included. I think there is also a trend and a desire to see use mobility data at a level that perhaps it's not intended to be used. So if bars and restaurants are closed, for example, using point of interest data to see what areas might have more foot traffic, that's not necessarily the best use of that because of the limitations of the data. So making sure that we're able to communicate that effectively is a really important piece.
Yeah, that's interesting. And the other thing I wanted to ask was the relationship between science and policymaking. So, many of us here are academic scientists, and it's been, for some of us, the first time that we've been really integrated with decision makers, people like you, and trying to understand how we can be useful. And, of course, we publish papers and put them preprints out and things like that. But have you seen the structure of the relationships between policymaking and academia change? Do you think that there is a different role that academics could play to support you? Obviously you're using a model and you're working with an academic team at Columbia, Jeff Shaman's group, I believe. Has that relationship changed? And how do you think there's anything that will, persist after COVID-19 in the structure of those relationships and how academia can help and support policymakers?
Yeah, absolutely. We were really fortunate. One of our epidemiologists, Sharon Green, had established a partnership with Jeff Shaman's group in, I think, January of this year, and had been connected to NYU and is connected to some folks at Harvard Chan School. And so having those relationships established and having data use agreements done quite early on really helped get us started. In March, things were happening very, very quickly. And so we really did rely on having all of the procedures in place to allow effective communication between the teams. I think that there are a lot of requests from policymakers of academic teams. I think one of the challenges in bridging that gap is communicating uncertainty to policymakers. It's not as useful to have uncertainty. They need a number to plan with. And so I think being able to find a happy medium between providing a number that folks are comfortable with to inform planning and getting things out there before it's been, typically you go through a whole peer review process, you're working with a lot of different teams. And I think this response forced academic teams to sort of go outside their comfort level on that so that they could provide rapid information. I think one of the great things was having multiple teams involved in that process so that they could work with each other to triangulate data and to feel comfortable with what was being used in the end. I think you're muted.
I'm just going to take one question from the chat. This is the first time we've seen Apple data used. Could you talk about representativeness here, given the affordability for Apple products? I think, well, I have opinions about that, but why don't you answer that and then we'll...
I think it's a caveat with all the data. One of the reasons that we use so many different data sources is that there are caveats with all of them. It's the same with SafeGraph data. It's the same with Google data. And then, of course, as we saw some demonstrations throughout the country, there was a tendency to turn off location trackers. So that, of course, also impacts mobility data. I think in general, there are many caveats with mobility data. I think it's important to recognize all of them. And MTA data is probably one of the closer ones that we have for that.
Yeah. And then one last thing, Andrew, on that point that Andrew is just asking about the interaction between public health in New York and the NYPD in terms of the use of this mobility data, and how that, if there was an interaction, how that went.
We don't interact with NYPD on mobility data, but I do know that they have access to anything that's available publicly. I'm not sure if it's being used by them, but we are using it with city planning for other health purposes.
Okay, great. Thank you so much. So now we are going to move to our final speaker. Where are we? Sorry, I'm just organizing. Okay, so now we are going to hear from Rafael Araos from Chile about the use of mobility data for COVID-19 response there. So welcome, and I will mute myself and let you go ahead.
Okay, thanks, Carolyn, for the introduction and for inviting me to talk today. So I'm an infectious diseases doctor who does research on bacteria, but I was early COVIDized, as everywhere during this year, and I was the chief epidemiologist at the Ministry of Health during the hard part of the pandemic, of the first pandemic wave in the country. I just left the position, but I'm still a consultant. So what I'm going to show you here is just my opinion and not necessarily express what the government thinks. So you probably are not well aware about the situation in Chile. We were hit really hard between April and the end of July. And then cases were started to decrease until we reached kind of plateau of 1,000 to 2,000 cases daily until now. Here on the left, you can see that as in everywhere and in most part of the world, the pandemic was asynchronic. So we have an epidemic curve that is driven mainly by Santiago, the most populated area of the country. But the north had a peak that was later than Santiago, and the very south is having a great pandemic wave now. So this asynchronicity, it's been a challenge, and one of the things that we've tried to do differentially over time is to allocate testing efforts in the parts of the country that are more needed. So here you can see that we are on the left, the upper left, we are doing almost like 12 to 15 tests per 1,000 people per week, which is a good number for us. And our positivity rate currently is around 5%, a bit lower. And our diagnostic delay, it's been corrected over time. But here on the right, in the lower part of the slide, you can see the number of tests that we are doing considering the incidence of cases. And as you can see, we need to do more, and this is very variable along the country. And in the about 70% the number of tests that we are doing. So the question is how to do this allocation of testing efforts more efficient, more smarter in a way. So this is what we call the active case finding challenge. So you have the medical attention positivity, you have the active case positivity, which is very different, and we have all kind of dashboards as you also have for trying to identify those hotspots. And we at the beginning we thought that it was a good idea to identify the hotspots of cases and go there and do the asymptomatic testing activity. So that was part of our design in terms of the active case finding. And this is a dashboard that shows some of the local situation.
What are you eating?
This is Coquimbo in the north of Chile, and this is Concepcion in the south. And here you can see,
No, I'm okay, actually, though.
you can see three curves. The upper curve is the medical attention curve. So people that is sick and looking for attention and the positivity. And the lower one is the positivity rate among those that were asymptomatically tested. And the middle one is the mean. So here in this part of the curves, they tend to be together, and that's what I would expect. So if you have a low number of cases detected by medical attention, and the positivity in the active case finding should be low. But we have some cities like Concepcion in the south. San Concepcion is a big city that has a really huge positivity rate from medical attention around 20%, and the positivity of the active case finding is below 5%. So clearly we are not, hitting the part of the city that we should be screening for asymptomatic infection. So how to improve active case finding? That's like the question that I'm gonna try to answer now. And of course, what we are trying to analyze is mobility. We were talking about that. So this is something that you've discussed before. I'm not the one that does the calculation, so I'm just gonna show you like the background. So knowing that social distancing and mobility impact directly or inversely the number of cases, we thought that maybe we combine the number of cases and the hotspot with mobility data, we were going to be able to have a better guess of where go to test people without symptoms. And this is okay. So this is a mobility study that we've been doing in a coordination with a research center of the name is Instituto de Sistemas Complejos en Ingeniería, and also a big cell phone company that has a pretty good penetration along the country. So it's kind of representative. And as you can see here, you have three cities: the north, the center, and the south, and different phases over time. And these spots show you where quarantines or lockdowns were indicated. And as you can see here and here and here and here, once you put a city under lockdown, mobility decreases and then increases over time. So the thing is, where go to test, even knowing that even if you are locked down, there might be a mobility that is driving transmission. So where risk, so where people that is at risk are going. So on the left, you have a map, a heat map that shows you Valdivia in the south, and show you the census areas that are accumulating or concentrating the active cases. So those people are in those neighborhoods, and they should be isolated, right? So they shouldn't be mobilized, traveling, because they are under isolation for 11 days in Chile. And on the right, what we tried to track was where people living in those hotspots, not necessarily those people that were actually the cases. So the people that were living here, where those guys were moving to. So you can see how the map changes, and we have some census areas that were not, in the hotspot map of the cases, but was telling us that people from these neighborhoods were traveling to these other neighborhoods. So the idea and the hypothesis is that if we go during working hours to test these destination zones, we were going to be able to find more cases with that active case finding. So this is a study that we are actually conducting as we speak. Leonardo Basso from the EC is the PI, but it works together with the Ministry of Health and a lot of people. And the aim is to be able to prioritize city areas for active case finding during working hours, with a focus on the destination zones. So we are trying to see where people is going and staying for work or for doing shopping, etc. And the idea is to generate a risk index for decision making. So we can inform the local authorities where should be done the active case finding. So we think that this index should inform the active case flow and ascertain, yes, because those that we know are isolated. Test positivity and the probability of finding asymptomatic or presymptomatic cases in each of the destination zones. And we use mobility data from this Intel company and epidemiological data from the Ministry of Health, which is basically active cases, confirmed cases by RT-PCR. And the idea is to try to estimate. So on the left, you have the epi data that tells us how many people is infected in the census zone 1 and in any census zone. And the idea is to try to estimate the floating population coming from this census zone to another census zone with a predefined area. And using this information from the prior week, so how many active cases were in this zone, and estimating how people were traveling to the other zone, we can have this index of how many people are going to be at risk in the interesting or in the zone of interest. And here's an example of what we actually end up having these three options. So census zone 1, 2, or 3. The 3 too few people, so there is not a good idea to go there. Census zone 1, it's okay because they have a nice number of active floating people with a lot of infected people, but the probability of finding a case is lower than this one, which is the ideal zone for testing. And so we try to convert this in this metric that tells us about the risk. Is specific for every city. So every city has one county, let's say county or neighborhood, that has the maximum risk, and everything is relative to that maximum risk. So every city has its own risk index, even so no matter if they have a high activity or low activity of the pandemic. So this is an example of Concepcion, and you can see here the darker, the riskier are the places based on where people is going from neighborhoods that have high risk of active cases. So the idea is to inform, and we inform this to the authorities, and they go to these places in red to test asymptomatic people, instead of doing the opposite that was going to the original places where people living with COVID were located. So this is the first data that just came back last week from Punta Arenas in the very, very south. We have so 3 active cases finding operative oriented by mobility by this index, and 19 operatives oriented by other metrics like hotspot maps. And the mobility index found 42 cases in these 3 operatives, and the other metrics we found 139 cases in these 19 operatives. So we were able to find, using our mobility index, 14 cases active cases per operative, compared to 6.4 active cases, which was the gold standard before the index. So what's the take-home message from this is that we're using, from taking actual decisions, we're using mobility and epi data to improve active case finding. We are escalating this to the whole country, and we are measuring the outcomes. And if we, I don't know, in a couple of months, if we are able to show that using this mobility index, we found more cases than using like regular hotspot data, it's going to be nice data to show, and a good example of how studying mobility can impact policy, public policy. So, thanks.
Thank you so much. So I'm interested in how your experience has changed over the course of the pandemic, and obviously you've shown proof of principle that this mobility index can be practical and useful. Have you found that decision makers are increasingly likely to turn to these kinds of analyses, or has it been how has that relationship gone for you?
It took us, I would say, like 6 months of iterations until we were able to work on a collaboration, formal collaboration between the Ministry of Health and one academic institution. And that university had the agreement with the enterprise, that the Cellphone enterprise. So after 6 months, we were able to articulate the relationship that were needed for making this work. And now they are pretty convinced that it's a good idea. So we're actually applying this to the whole country. And of course, we're still we're designing something in order to be able to show that that actually the mobility index is better than the gold standard, let's say gold standard. But they are very enthusiastic about the results that we've seen, and so I would say that now it's an open road.
Right. We have a question from Pamela, who says, how do you take demography into account? It might be important to find, places where people might be more likely to be hospitalized and so on.
Yeah, so far, the only variables that we're taking into account is the number of active cases and where those people are traveling. But of course, there's a lot of room for improvement, and the risk is going to be very different in different parts of a particular city. For example, in Santiago, we know that the city, as in many countries of South America, is very divided into high or low income neighborhoods, and probably those in the low income neighborhoods live more. They are densely populated, and probably the risk is higher. But we're not considering that yet.
Okay, thank you. Well, there are lots of questions coming in. So Andrew, why don't you ask, do you want to ask your question? Because it seems like there's about 5 questions.
But I'd put them all in the same box. Yeah, I was interested in the data agreement with Intel. Is that an open-ended data agreement, or do you have to constantly make a case to refresh that? And I don't know if I caught the specific data protection requirements that you have to comply with from Intel. Related to that, have you looked at the app-based mobility data sources? I mean, we talked about Google and SafeGraph earlier. Facebook has been used by others within Chile, and I'm just wondering how that intersects with the way that you're looking at the data from Intel.
Yeah, well, the story is that actually I'm not the PI of the research center that had the agreement with Intel, so I'm not aware about the specific conditions of the agreement. I'm pretty sure they have to renew it, but they've been working on this before, so it's probably one. It's not like you have to renew it like every month, something like that. And Intel has a very high interest in doing this academic partnership. So I can come back later and email you with more specifics about that. And regarding the data requirement, we have nothing. So the only thing that we get is the final destination of people that is coming from. So we deliver anonymized data to the research center. They get anonymized data from Intel, and they do the mathematics and the analysis, and we receive back the index. So the only people that is getting some kind of individualized data is the research center. Not a lot, but they do have something, and they have confidentiality agreements with each part. So that's kind of the way that we've moved around this part. And why we started to work with them, because they were ready. So if and this is so we have to work. So I was really convinced that it was good. So they were able to start at the beginning of the idea. So that's why we started with them. But of course, the idea is to make it stronger, include more companies eventually, or yeah, using freely available data. So it's something that we're working on. So.
Yeah, I think a lot of this was opportunistic at the beginning. It just kind of what was available and who was there to help. I guess I want to ask this question to you, but I think it's relevant for all of the panelists. So maybe we can start with you, Rafael, and then the others could speak on this too. in general, I think that, and it relates to the question that Cheyenne Chaudhry put here in the chat as well. So at the beginning of the epidemic, our analyses have shown that the relationship between growth rates, case counts, such as they were, well, Rafael is gone away somewhere, but that's okay. So the relationship between case counts, the epi data, and the mobility data were quite tightly linked at the beginning, because the main driver of the epidemic was human behavior and these lockdowns and so on. As we've moved along during the year, A, we have some pockets of immunity starting to emerge. B, we have different interventions that have been layered on top, like mask wearing and so forth, that are not that are going to kind of change the relationship between mobility measured by mobile phones and the epidemiology. And so I wonder, for all four of the panelists, but starting with you, Rafael, how do you think about integrating the shifting epidemiological parameters as we move on? Because it will change, and the relationship between 10% drop in mobility will be different now than it was in March. So I guess we can start with you, but move on, because I think it's something that we all have tried to kind of grappled with.
Yeah, well, again, for this particular question, my role, it's been like being an articulator and try to leverage all the work that the academic centers are doing. And I think we have a nice window of opportunity thinking about like a group of metrics that we need to use in order to understand what's happening in every part of the country. So for everyone, for the US, for Chile, for everyone, the pandemic is, very specifically located. So really need to understand it comprehensively. So I show you very rapidly one of the dashboard that we have with all the metrics. And the idea is to include mobility as one more metric to inform policy, because it's there's still a lot of work to do in order to understand what really means. For example, we've seen cities where mobility comes back to close to normal, but they still have low number of cases, probably because the kind of movement they are doing are not riskier. Like we saw with the paper from Nature a bit before. So the idea, to again, like snowball effect, my idea is to just with this data to include the indexes that we are developing, and not only the index, also the curves of mobility within the dashboard, and to take into account how people is behaving. So we can include that and kind of push for more data to come. So just snowball effect.
Yeah. Do any of the other panelists want to comment on that? Greg, you have your hand up.
Sure. So yeah, just to build on that, I agree with what Rafael said. But I think we now have a number of leading indicators of future cases and syndromic surveillance data from healthcare agencies. There's the Delphi group out of CMU recently had a blog using the percent of visits that were for COVID-like symptoms. So there's, other people have used Twitter signals or Google Trends data. So, mobility, I see it as just one of the many leading indicators, and the relationship between each of these leading indicators and case counts and subsequent hospitalizations and deaths will change over time. So it's important not to say this is the indicator or this is the relationship between this leading indicator and this outcome, but rather to take it in a sort of continuous learning model where, and I think Jure's work is very amenable to this. So, it's continuously learning. It's like saying, now what's the strong predictor? Because you're right, mask wearing is going to change things. At the beginning, we closed parks and beaches and things like that, which makes no sense, right? Like, we just didn't understand that at the time. Now we know that, in fact, outdoor activity is relatively much safer, and we want to encourage that rather than, indoor gatherings. So just seeing it as a number of leading indicators whose relationship is time varying, I think, is the approach.
Jure, do you want to comment?
Yeah, what I wanted to add, so right, like our approach is very kind of microscopic in this respect, right? And we've been now applying the the model to the most recent data, and what we find is less good fit, and we kind of find that the model is likes to over predict given versus the reported number of cases. And what we did then, actually we used some survey data about mask wearing. And it turns out that if we integrate that as a signal, so we don't make the model more complex or have more parameters, it's just integrate the mask wearing data, then the model starts to fit quite well as well. So basically, I think what it says is that, let's say, mask wearing has a very important effect on lowering the transmissions, and that the level of mobility which we have right now we'd be in some sense way worse off if it weren't for masks and other measures. So we are kind of extending our work to better model the landscape of the virus that has changed quite a lot since the first wave.
Thanks. Jaimie, did you want to add anything?
Yeah, I mean, everybody's covered so much of this. I think importantly, in addition to all of this, we do in our models integrate the both mask compliance and efficacy. I think it's somewhat still unknown.
How do you measure it?
Good question. So I don't know if you saw the New York Times, they did a mask adherence survey. It wasn't scientific, but it was an interesting snapshot. So we've piloted a couple of similar things. And I think one of the aspects for New York City that's really great is that people are pretty compliant with masks. It's quite different if you look at perfect mask adherence versus any mask adherence. But in general, the mobility data are extremely useful when we have things like stay-at-home orders or business closures or recommendations to populations to consider staying at home or limiting in-office work. We saw very early on that helped, that there was a significant drop, and I think we're hoping to see the same thing to complement our other mitigation measures. It'll also help us really understand what communities could either use more incentives to stay at home, or if they're not able to stay at home because they're essential workers, what communities we can further support with PPE distribution and other types of things to really help those who really can't limit their mobility during mitigation.
Yeah, I have a question in the chat from Nishant, Sacha, do you want to ask your question and then I will?
Sure. Gregory, I was just wondering in the decision at Google, and if you had some insight into the decision to make this fairly sort of manually engaged task, right? You had to click on the, download CSV file. Initially, there were only PDF files, and clearly there was a data protection strategy, while, other technology companies may have gone down a different route, like Facebook Data for Good, for example. Just your thoughts on where, what those discussions were like, why that manual step, whether that's going to change in the future, other ways in which data protection could be addressed.
Yeah, it's a great question. So I was not involved in the discussions. Those are high-level discussions. As a visiting scientist, I wasn't involved in those. But what I saw as a consumer was that the PDFs allowed government officials to very, very quickly use the data, without any in-house analytic capability. Like you saw, prime ministers in multiple countries sort of say, hey, here we have the Google mobility reports. And they had a very visual and quantitative instrument right in front of them. And so I can only imagine that was a deliberate strategy to make the data very easy to use with even no technical expertise on the part of users. Then there was immediate pressure to release the data in a more quantitative way, so by researchers, so that more technically sophisticated units could incorporate those data into models and so forth. And we very quickly wanted to do that. Those were the discussions to how quickly can we release the data. And so it wasn't a data protection thing so much, because the metrics are the same. So it's not that there was any more or less information in one format than the other. I think it was just about making the data as easy to use as quickly as possible. Again, that's my personal viewpoint. I wasn't involved in those discussions.
Thank you.
We have we have 2 minutes left. And there's so many questions, and I want to thank our panelists so much. I guess if somebody does want to spend the last minute, I think that this question about how mobility data might be useful for the vaccination campaign seems really important. Jaimie, I wonder if you want to just say something about that, whether there are plans to in New York, how you think it could be useful.
Yeah, that's a great question. I think it's a really important one as well. So as you probably saw here in the United States, the CDC has released a phased rollout proposal. And so it depends on the vaccines, but in general, we're looking at mobility data similar to the way that we used it for the testing operation. So looking for areas that have high traffic where people can easily get to it, or where people who have limited access to transportation will be able to access it. There was a question about demographic variables. We also use demographic variables and health indicators to ensure that we're providing support to the populations that have the highest burden and highest risk of a severe COVID experience.
Interesting. So it's more of a like logistics and rollout, how to do the rollout itself rather than prioritization or anything like that. Interesting. Thank you. So we have run out of time. Sachit's saying that we will keep the chat room open for a bit so that the speakers, if they have a few minutes, can respond to questions. And we'll shut off we'll all leave at 11:35. If you have to leave, that's fine. I just want to thank all the speakers again. This is really fascinating. One thing maybe in the last few minutes, if you can stay, we didn't get a chance to talk about privacy very much. And I think it's something that's really important. These data sets are really different. They span the spectrum in terms of data security and privacy, and probably the data use agreements are different as a result, and their representativeness is different, and they answer slightly different questions. I wonder if there's maybe Jaimie and Rafael or Gregory and Jure want to comment on this. How do you see, as a researcher or as a policymaker, epidemiologist, how do we think about privacy for these data sets? And are there concerns, or do you think it's going to be that there are no concerns and it's fine? I mean, I've seen the use of data sets that I personally am a little bit hesitant about become very routinely used. And I don't know if on the government side that's being talked about at all. What do you think?
Yes, it's a concern. It should definitely be addressed. I think that the data owners themselves have implemented quite a few procedures in order to improve privacy for the people included in the data set. I know that there's a question about SafeGraph. I mean, it's all about the use and the use of the data. And I think that making sure that there's an understanding of what the data can and cannot be used for is very important.
Yeah, I think it's interesting to see the spectrum of processes to anonymize the data at different levels, from sort of, you can see across these publicly available data sets, very different approaches, very different levels of granularity of spatial resolution, from the census block group level of the SafeGraph data to county and national and some other data sets. And it just emphasizes that there is no standard, right? And that's, I think, a really interesting ethical and AI discussion of, who should decide? Is it the user exclusively? Is it governments? Is it the companies themselves? I think there's a really interesting discussion there around privacy.
Yeah, same here. Sorry, I'm outdoors, so I'm not sure if you can hear me. But yeah, it's unprecedented. So here in Chile, it's also a gray area. I think we are approaching this case by case basis, but definitely it's going to be a part of the discussion since we are combining mobility data with personal health data. So that's protected here in Chile as well as HIPAA in the US, and I'm sure in a lot of part of the world. So it's going to be a big issue, I think. I think it's not, as you said, Caroline, I think it's if you discuss these and regulate it, okay, there shouldn't be problems. I think it's we share all the kind of information, but it's something that at least here was not discussed before.
Unless you want to weigh in, Jure?
Yeah, I think these are good points. I mean, in some sense, I think it all depends. Like it is all about what is this data used for? Do people understand when they click on OK or they click always use my location and things like that? That they are really giving this data away. I know in Europe, for example, it is possible to collect this type data in a GDPR compliant way. And then aggregate it to some level that the data is kind of de-identified or individuals cannot be identified. I think the value of mobility data is clear, and I think there is a way to kind of I kind of consider this kind of complex set of questions, considerations in such a way that this can be used for the good of everyone.
Yeah. I totally agree. Okay, well, thank you. I will let everybody go. It's been a really fascinating panel, and I hope it's okay if we are able to share the recording with people who are here. Let me know if not, we can remove bits. And thank you everyone for joining, and hopefully see you all soon.
Yeah, thank you very much. Have a nice rest of the day. Bye-bye.